right. Welcome everyone to our last walkie-talkie of the year. We haven't got a microphone today, so we'll just have to ask you to listen up. I'm Mandy Penkin, for those of you who don't know, and together with Nicole Katz and Nikki Lookman, where's Nikki? There. We are your hosts of Maccabi Life Walkie-Talkies. We're very pleased and happy to introduce to you today Ginni Mansberg. Ginni is a GP and she focuses on women's health, and she's got a long litany of credits. So I'm going to tell you that she appears on Channel 7 on the Sunrise Show, the morning show. She hosts Embarrassing Bodies Down Under, which isn't to say that only embarrassing bodies are down under. It's spread all over the world. And she's also the proud author of a book called The M Word, and we'll talk about sales of that afterwards. So without further ado, we are going to kick off a little bit of a Q&A interview with Ginni. And at any time, we've got some questions that were posted prior to the talk, but at any time that you've got questions along the way, please just raise your hand, shout out, and we'll take your questions. That sound okay?
Yeah.
Awesome. Okay, so thank you, Ginni, for coming and talking to us today. It's a topic that is very dear to probably everybody's heart over here, and a lot of, I guess, middle-aged women. It's something that is quite difficult to deal with. And we're recording today's session just for everybody's awareness and knowledge, so that we can post a link to paid up registrants after today's session. So we sort of kick off maybe with a little bit of background. What is menopause? When does it happen? And just give us a quick history, if you don't mind.
So I'm not going to ask for a show of hands because like we're all uber fertile here, so it's just for a future date. So technically, your ovaries are just pumping out. Their whole purpose is to make babies, right? They just, like, by some miraculous means, they make egg of the month. She gets chosen. She goes out in her little bubble, and then boom, she bursts, goes off to meet the sperm of her dreams and make you a nice baby. And what's left of that bubble turns into the corpus luteum that gives you progesterone. So in the second half of your cycle, because we all have those, we've got a lot of progesterone pumping around, and that is your chill out hormones. That's awesome. And that compares to the estrogen that goes right through your cycle. That is, I call it New York City. It's like your go hormone. It gets your brain going. If you don't have it, you might feel maybe a little bit less in the brain. And all of a sudden, your ovaries go, you know what, I'm really jack of this making babies crap. I'm over it. So I'm going to start not ovulating too well. So it makes estrogen not so good at the whole ovulation making progesterone bit. So that's your perimenopause stage. A lot of us are really familiar with that because you don't sleep as well. You might be a little bit anxious. 1 in 4 women will get anxiety. And then when it's been 12 months since your last normal period, that's the day you officially hit menopause. It's a single day. It's a single event. So you open your champagne because that whole contraception shit is over, and that's really good. So that's your day that you hit menopause. And from then on, your ovaries have gone into full-on retirement. They are not doing anything for you at all.
Right. Okay. So we've hit menopause, but what actually happens to our body? Most of us know about the hot flushes, and we'll get to that in a minute. But what else are the changes that we can expect?
And they don't always start once you've gone through menopause. So a lot of this stuff will happen in perimenopause. 75% of women will get some sort of hot flushes. And by the way, the average age in Australia is 51. So that means your last period is sometime in your 50th year. Some people are much older and still going. So during your perimenopause, sometimes you'll get your hot flushes. You'll have your mainly anxiety, lack of sleep. But once you lose your estrogen, you're going to have things like brain fog, aches and pains. Then let's talk about your bladder and your vagina, because no one's going to ask me about it. So that's my favorite part of the body. I love a good vagina. Someone brings out a penis and I have to examine it. I'm like, I don't even know what that is. I don't do penises. I'm excellent with a vagina. Bring me any vagina. I'm very happy. So she basically loves estrogen. Estrogen turbocharges her, and that's how she makes fluid. And your fluid is like the self-sourcing pudding. It's like your self-cleaning oven. The modern oven was invented by Mother Nature when she invented the vagina. It is a perfect unit. It's whatever goes in, don't worry about it. It all comes out with a nice cleaning fluid, but you need that fluid. And if you don't have that and the cells get a bit small and the collagen and the elastin that we all know about in our faces, that disappears from your vagina as well. So an older vagina is much smaller. If your husband tells you that your vagina is too big, it's not. His penis is too small. It gets smaller as they get older. But she gets drier. So sex is not fun. It's itchy. And your bladder goes to shit, basically. And if you've had a couple of kids, that's just not a good scene. And jumping on a trampoline is something you might not want to. It's a high risk activity. Might want to wear some black leggings for that purpose. We've got a whole lot of stuff happening downstairs as well. So we'll need to talk about her, because we'll bring her out for a bit of an airing and give her a reno while we're here today.
Fair enough. And I think that we're going to get to that topic about what to do about it in a second. You touched on perimenopause, and you kind of indicated some of the symptoms. Can you give us a bit more detail about how do we know that we're in perimenopause?
So there's no blood test for it. I'm often asked, can I have a blood test? I think I might be in perimenopause, but what's happening chemically is that every day is different. So a blood test will be a single point in time, but it might be different 3 hours later, and it'll definitely be different the next day. So a blood test is spectacularly unhelpful during perimenopause. So what it is it's at the first stage of perimenopause is when your ovaries are still capable of making estrogen. So you get lots of estrogen, but you don't have any progesterone. And the result of that is mainly around your mental health. So it's anxiety. 1 in 4 women will get quite anxious. Sleep is terrible. So often perimenopausal women will tell me that they can fall asleep. They're dead. They'll fall asleep on the couch at 8 o'clock. But from midnight, they're up every hour. They might need to be going to the toilet. They might just be, they're not even sure what's going on. With or without hot flushes, you're often up at night and you can't remember the last time you've had a decent sleep unless you've convinced your doctor to part with a bit of Valium for you. So it's not a great time for your mental health. Your periods go all over the show. So 1 in 4 women will get horrifically heavy periods during that time. So 80% of those women will never find a cause. It's just the lack of progesterone. I always think of progesterone as being like the mum. So when you know, estrogen's the dad. So when you send dad out shopping and you put something like toilet paper on the list, he'll go and buy like 18 packets of toilet paper and put them in the wrong part of the house, so you never find them anyway, right? So you just got this completely chaotic situation. But then mum comes along and goes, oh, I'm going to put it all in a pantry at a place that I can find. Progesterone is the great organizer, and it organizes the endometrium, the lining of your uterus, beautifully. If you don't have progesterone, you can have incredibly heavy periods because it's just very chaotic and disorganized in your uterus. And so you'll have these irregular periods. As you get to the end of perimenopause, the amount of estrogen your ovaries are capable of spitting out, it really goes down quite a lot as well. So you get all the other symptoms, the hot flushes, the brain fog, and aches and pains. I actually should say that there was one really large study, the biggest study of symptoms of the menopause. And while 75% of women get hot flushes, often they manifest as night sweats. It's not always the hot flush that you think about with going red and just, it's often just you can't sleep at night because you're so hot. If you get all of that, we've got lots we can do for that, but aches and pains are really interesting. And they actually have been found in studies to be more common than hot flushes. And that's particularly for women of Asian background. And we have 1 in 10 Australians is Asian. So we have to really consider that it just can be sore back, sore legs, it means that you can't exercise as well. And then a lot of the other things follow as well.
I might be part Asian.
I was actually thinking, yeah, definitely. Japanese, I think. Yeah,
there you go.
It's the accent that gives it away every time.
Absolutely. So let's talk about that hot topic of hot flushes. Tell us a little bit about how do you deal with them? Is there a way to alleviate those symptoms?
So I mean, I don't need to tell you guys all the things that you do, like dress in layers, strip off if it gets hot, have access to a cold drink, carry a fan. Personally, I think that's shit. I mean, like, it's just, I mean, sorry, of the 75% of women who get hot flushes, 25% have very mild symptoms. And then that sort of thing is fine. You know, if it's happening once or twice a week, that's totally fine. But 25%, so that's 1 in 5 women altogether, consider their hot flushes unbearable. And for that, we have a lot of treatment. So we probably talk about hormone replacement therapy, which is 96% effective at getting rid of hot flushes, and probably is the only thing that's going to wrap up brain fog, mental health, aches and pains, will help the vagina, will help the bladder, will help everything. We'll talk about why people just go, no, you've got something else to give me. In terms of complementary and alternative therapies, we do have some evidence for weird things. Hypnotherapy, Cochrane review, big review of lots of studies, found that hypnotherapy works. It's the only thing it works for. It doesn't have any evidence for anything else. Hot flushes, it does. Pine bark, but not a lot. All the things that you think, and the studies are small, right? Yeah, pine bark extract, but the studies are small, right? And it might be 100 people with a small placebo arm, and it goes for 6 weeks. Now, in most studies of hot flushes, no matter what we're studying, the placebo effect is up to 75%, which is very similar to pain trials. So you've got to take all of these complementary and alternative therapies with that in mind. I love a great placebo effect. If it works for you, go do it. Like, there's nothing wrong with a placebo, but biochemically, there's not always a lot of reason to believe in it. And some of them have interactions with medications or other complementary therapies, and you just got to be careful. And I would get it from a pharmacist and ask your pharmacist if it's okay to take it, rather than just going and picking it off the shelf or going and subscribing to a website that delivers things to you, because they won't have that knowledge to say whether what you're having is dangerous. We should talk about black cohosh. So I don't know, is anybody here on black cohosh? Formula product. So Formula is black cohosh. So in Australia, there's a black box warning. It's the only country in the world talking about liver disease and pancreatitis. That's not a black box warning anywhere in the world, but I have a patient who got it from some Lisa Curry-Kenny black cohosh that she ordered online and was admitted to hospital, and 2 years later she's still got pancreatitis. She's lost so much weight. She's an absolute mess. I mean, I'm not saying don't use it, but you do have to, there are some risks from it. And we don't know who's going to get it. We can't predict, we can't look at you and go, right, you shouldn't have it or you shouldn't have it. It can happen to anybody. And my patient took it because she had breast cancer and was not able to take HRT. So that was not an option for her. She heard she had disabling hot flushes because she's on a medication that suppresses her estrogen. That really just turbocharges your hot flushes, and it was dreadful. But she's probably maybe a little bit worse off. There are other medications, so particular antidepressant medications. So Lexapro or escitalopram is a good one. Effexor or venlafaxine is another one that is often used. They are effective. There are a lot of other antidepressants that are not effective. There's one that I actually use quite a lot for women who've got bladder issues. So if they have a lot of incontinence, so weeing a lot at night, there are 2 forms of incontinence, urge and stress incontinence. The one is when you can't jump up and down on the spot, because then you have a black pants moment. Then there's also the urge incontinence, which has got nothing to do with estrogen. It's just a matter of getting older. And that's when you need to pee. You feel like, I need to pee. Oh my God, I need to pee right now. I need to find that toilet right now. And there you're in a high risk situation there. This is when you think, I'm going to go for a walk with my girlfriends, but I need to know that there are toilets along the way, because when that moment happens, I'm not going to be able to wait for that extra 2 hours. I'm just going to have to go. That is urge incontinence. There is a great medication for that. The accidental side effect is getting rid of hot flushes as well, and it's spectacularly effective. And so it's Ditropan. Ditropan. I use that. No. All these things are on prescription. And there are Oxytrol patches, so you can get it as a patch as well. And I use that a lot, particularly for women who've had breast cancer, because it's just so effective. No such thing as a free lunch with medications. Everything has side effects. So dry mouth and constipation. Let's face it, every medication causes constipation, and every menopausal woman is constipated. We won't need to discuss your bowels right now. It's just like, it's a ubiquitous thing. We'll just add it into the mix and just go, you know what, take some fiber, get yourself on your Metamucil. It's just going to be extra helpful.
That's one of my favorite emojis, the poo emoji.
It's like, oh, I'm so happy to see you.
So you touched on HRT.
Yeah.
Can we talk just for a few minutes about why there's a bit of a negative connotation
Yeah.
around HRT and whether that's a valid connotation?
I mean, I don't know if anyone would be happy to share, but has anyone been offered HRT by a doctor and just felt like I don't want it, I'm not comfortable to take it? So
Has anyone not been offered
Yeah.
it by a doctor because they
or a doctor refused to give it to you, saying that you can't have it because it's too dangerous. So I'm going to go back. This is a bit of a history lesson, but it's actually really important. So there was a really massive study in the United States called the Nurses' Health Study. And this is a really important study because it took a massive group of women and followed them for 20 or 30 years. And what they found that was kind of weird was that women who were on HRT, and at that stage in America, HRT was basically, you hit 50, they put you on HRT. It was like the elixir of youth. And it had almost become a bit gross. Men were sort of in control of that whole industry, and they just went, women who are not on HRT are foul. So we're just, we're going to put every woman on HRT to keep her young, which is a bit gross. That's not what you use HRT for. But they basically found that women who are on HRT had less heart disease. And they went, you know what? Let's do a massive prospective trial where we're going to recruit 160,000 women. The average age of the women for this prospective trial was 63. So that is not an age where most of us are starting to go through menopause. Some of us might be uber fertile and going a little bit longer, but 63 is not normally, we're normally well through it by then. And then they randomly assigned women to either get HRT or a placebo. They didn't ask them about their hot flushes or any menopausal symptoms. It was simply a study to look at what happened with other health outcomes. So they looked at bone fractures from osteoporosis, a whole raft of cancers, including colorectal cancer and breast cancer, and heart disease incidence. And then what they had to do, when you look at the way they randomized it, which was completely randomized, but 1 in 4 people in the HRT group were over 70 when they started the HRT. The HRT that they used was a Roche product called Pempro, which is Premarin, the very old style mare urine estrogen, which no one in their right mind would ever use anymore. It's so old, we just don't use that. It is extremely strong. It's a very high dose of estrogen, very close to the pill. We just don't use that. And then they used a form of progesterone called medroxyprogesterone acetate. So that's in a combination product. By the way, we have to give you progesterone if you have a uterus. And the reason is if you have a uterus and we give you estrogen and we don't give you progesterone, we can actually cause overgrowth. Remember what I talked about with the pantry when the dad goes shopping and puts all the toilet paper in the wrong space? It's the same thing with your uterus. We have way overgrowth of endometrium and it causes, it's been linked to endometrial cancer. So we can't give you estrogen without progesterone. We have to do that. So they use this combination product and they had to stop the study. And in 2002, they finished the study early because there was a subset of women who were older, overweight, who were getting breast cancer. So let me put some numbers around this because this is really important. For every 10,000 women on a placebo during the course of that study, 30 women developed breast cancer. For every 10,000 women on HRT, 38 got breast cancer. So that was an increase of 26%. And they said, we have to terminate this because we are really worried about causing more cases of breast cancer, and we're actually going to get sued. But the way that the headlines were read, it sounded like HRT caused breast cancer. What we know is that for groups of women who are sort of, the average age of that group was 68, a quarter were over 70. None of them were monitored for the need for HRT for symptoms of menopause. When they dissected out the women who started in their 50s, they actually had no increased risk of breast cancer, even with that particular form of HRT that we would never, ever, ever use anymore. But the headlines read, HRT causes cancer. And overnight, 80% of women in the world who were on HRT stopped. They threw it in the bin. Roche went bankrupt, right? So they got sued out of existence. The company that bought them had to settle another $300 million worth of lawsuits. Wow. Because every woman who had breast cancer sued the HRT company. And every doctor went, they were doctors who were getting sued left, right, and center. And doctors said, I don't want to get sued. I'm not prescribing this. And even though every menopause society in the world said, this is leaving women in the dark, this is unfair, it's not even true. there was a 35% reduction in colorectal cancer. And in terms of prognosis, you don't want colorectal cancer. That is a far worse prognosis than breast cancer. There was a 50% reduction in osteoporosis fracture. And for women who've got disabling hot flushes, it's life-changing. But that 26% increased risk in breast cancer was enough to just kill off the entire industry. It didn't just kill off the industry, it killed off women's health research, because every drug company just went, too hard, not doing that, I'm out. And that was a really huge issue, the legacy of which all of us are dealing with today. There are now drug companies who are getting back into the women's health space, but they were too scared. And that's just a travesty, I think, on women, in particularly in a study that was run by men, for purposes that was not explained to the public. I mean, when I tell you that, do you just think, well, I would never use HRT? It's not something you would say. I can tell you that something that has a 96% benefit in terms of reducing hot flushes, that it helps your aches and pains, that it helps your mental health, that it helps your vagina, it helps your libido, which we haven't talked about. It helps a lot of things. Why would you say I'm going to discount it? I'm not saying it's for everyone, and you certainly would not be doing it as an elixir of youth or because you want to look prettier, because it does do great things to your skin, but you would not be doing it for that. But if you need it, I don't think women should feel afraid to have it. That's all I'm saying.
And there's better HRT.
So we do a risk benefit analysis. Sorry, so the question was, what if you're over 60, you've not been on it until now, and you're thinking, maybe I'd reconsider. So what we know is that from that Women's Health Initiative study, we saw that small increase with that particular HRT. So I would be using a different HRT. We use micronized progesterone, which is a safer form of progesterone. We use transdermal estrogen. Generally, that's a safer form of estrogen. So whether it's a gel or a patch, that sort of thing. We know that being overweight is a very big risk for breast cancer. We know that the increased risk of breast cancer in that study was about the same from having 1.5 glasses of wine per night. So you could reduce your risk of breast cancer and cancel out your risk, if there is any, from taking HRT by just reducing your drinking. So we could say to you, as long as you understand that we can't exactly quantify the risk, but there may be an increased risk there, slightly increased risk, but we're going to give you for breast cancer, but we're going to reduce your risk of colorectal cancer and osteoporosis fracture, and we're going to make your life more bearable. But maybe you want to make sure you're in the healthy weight range. Maybe we want to make sure that you're not drinking too much to sort of mitigate your cancer risk. And I will always do a 3D mammogram called a tomosynthesis. It's really worth having because apart from the fact that it's less uncomfortable, they do a BIRAD scoring on your breast. So we rate breasts from BIRADS 1, 2, 3, 4, which is a radiological risk of getting breast cancer. BIRADS D, which is the BIRADS 4, increases your risk of getting breast cancer by 36% over your lifetime. And for those women, I'll offer them yearly screening rather than 2 yearly screening. So that's something else that we could do, because we know that the prognosis for breast cancer, particularly when it's caught early, in Australia at the moment, 50% of women catch their breast cancer by a screening mammogram, 50% by feeling a lump. The ones who get it on screening mammogram, their prognosis is outstanding. It's so good. It's high 90s 5-year survival rate. Get it if you feel a lump, that's not as good. It's an 88% 5-year survival rate. It's not bad, but it's not as good because we're finding it more advanced. The earlier you find your breast cancer, the better, but it's got a better prognosis than colorectal cancer, no matter which way you cut it. Colorectal cancer is less common, but it's a bigger cause of cancer death in women.
So can one be on HRT?
Yes. So the answer, this is a bit complicated.
Did you all hear that question?
The question was, how long can you be on it? So we say from every menopause society, and I belong to 3 of them, we all say you can use HRT for as long as you need it. The thing is, once you're on HRT, you don't know you need it anymore, right? Because you feel great and you don't need it anymore. And so a lot of my patients say, what should I do? So what I would do is the standard starting dose of estrogen is a 50 microgram dose. That's just, don't worry about it, but that's sort of your dose. It's a 50 dose. And so what I say is wait till winter. Mind you, this summer's just so crap. We probably do it this summer, but wait till winter, cut your patch in half or halve your dose of the gel, or if you're on a tablet, cut it in half. And let's just see what happens over winter. it will probably take 6 to 8 weeks for everything to come back if it's going to happen. For some women, it takes 3 months. You can always go back up again. Wait for 6 to 8 weeks. If you feel fine, cut it out. You don't need it anymore. It's fine. But you can continue it on forever. And that is the absolute, by every menopause society. There's no one who says differently. No one needs to get off it after 6 years. There's no arbitrary time. Let's face it, hot flushes, if they start after menopause, last for 7.3 years. If they start before you've gone through menopause proper, 11.4 years. What the hell? Like, sorry, well, what's the point of saying you've got to be off HRT in 6 years? That's just shit. Like, we would not do that. That's torture. So, because the hangover of the Women's Health Initiative is that pharmaceuticals got out of the HRT game. You try and find something on the pharmaceutical benefit scheme now. This stuff is so expensive. It's so discriminatory against women. But they stopped investing in it. And a lot of drug companies, whether we like it or not, sponsor educational events. Once they're out of it, they're not educating the doctors. So, and this all happened, I'm 53 now. So I'm in exactly the age where, as I went into general practice, this happened. And all of my training in menopause just evaporated. Everything I know is self-taught and by joining menopause societies, but most doctors have got no idea. How are they meant to know? It's not taught in medical school. It's not taught. Most gynecologists know nothing about it. They know nothing about it. I hear advice that my patients tell me that their gynos have given them that frankly horrifies me. I'm like, what are you doing? Like, it's so bad. So, but it's a systemic failure as a result of this one study that has meant that the entire profession has just gone, oh, too hard, don't want to know. And they tell women, it's just being a bit hot, don't worry about it. Use a fan. And I just think, wow, you know, you've got women whose mental health has been 100% their whole lives and who hit perimenopause and are basket cases. And what we're going to withhold something that could actually help them, that's cruel. So yeah, it's a bit of a passion for me. It's yeah, it's just there's a lot of doctors who are still scared of being sued, and they're scared of HRT, and they're scared of women's health. And you know, there are doctors. So one of the women who well, there's nothing else, and it's got benefits and other stuff.
To talk to Ginni.
But I mean,
offline.
one of the women who was in this book that I interviewed, who's an expert for this, so she's like the world expert on vaginas. One of our sisters from inside our community, but oh my God, I love her. And she went through menopause, went to her GP and said, I'm having horrible hot flushes. And she's like the world expert on menopause vaginas. And her GP said, if you want to have that, you're going to have to go to a specialist. That's dangerous. And she went, okay, time for a new GP. But find a GP who's a member of the Australian Menopause Society. We're as rare as hen's teeth. There is currently 0 in the Northern Territory. If you're a woman in the Northern Territory and you want to find anybody, specialist, anyone who's a member of the Australian Menopause Society, good luck. You're going to have to do it as telehealth to somebody who, you know.
So if it's okay, if we can just touch on one thing that's a little bit closer to my heart. So I'm a breast cancer survivor, and my breast cancer was estrogen and progesterone positive. I can't have HRT. What are the other alternatives that people who can't have HRT can use? You touched on some before, but if you can just...
So the question is around estrogen receptor positive breast cancer. So of all the breast cancers in Australia, so breast cancer is the most common non-skin cancer amongst Australian women, but nowhere near the top of cancer killers because it's got a great prognosis. Of all of those cancers, 50% are estrogen receptor positive. The others are not. So if you do not have an estrogen receptor positive breast cancer, a lot of oncologists will still not allow you to have HRT because they're paranoid about it. But most people who are oncologists in menopause societies, there's a very popular one in Prince of Wales Hospital. They will 100% allow you to have HRT. But if not, we try and kill two birds with one stone. So the idea would be to take a very thorough history and look at what is going on for you and say, hey, what is your priority? So if your bladder is making your life worse, and as a result, you can't exercise because you've had to give up running, you can't do walks that are as long as before, going to the gym is a nightmare because you're going to wet your pants all the time, then we worry for your cardiovascular health. And as a result of being on tamoxifen or Genox, one of the, or Femara, which is a different kind of drug to suppress estrogen, you have an increased risk of bone of osteoporosis and but also heart disease. We need you to exercise. As a result of that, something as simple as giving you something that will help your bladder and your hot flushes is a really obvious choice. If your predominant symptom is a mood symptom, if you are mostly got horrible depression, or a lot of women don't recognize that it's depression, they're just cranky and yelling at everybody all the time and want to kill the kids and want to kill the husband and want to move out and whatever, then we would probably suggest one of the more effective antidepressants that has hot anti-hot flash activity as well. So we would tailor the treatment for you. We would ask you to run your complementary and alternative therapy by your doctors. And the reason is that soy, so there's a lot of red soy around and on the market, it works by augmenting the estrogen receptor, and we do not know yet what that does to breast cancer. So we would say avoid the over-the-counter soy things because they may not be safe. We don't know that, but we would avoid that.
What about for like lubrication type reasons?
Let's talk about her. Can we talk about her? Now I'm in my happy place.
Lubrication.
Okay. So I'm not going to ask any of us about our libidos because they're all fabulous and we're all going to go home and have amazing sex today. But one of the things that happens as you go through menopause and your vagina is not as healthy as she once was, we've lost collagen, we've lost elastin, she's got smaller and she's not lubricating very well. So sex is like being rammed with a sandpaper covered battering ram, and it's just not a lot of fun. What are the numbers we're talking about? By the time we hit 65, 80% of women have what we call vulvovaginal atrophy. Sex is uncomfortable. It is often itchy down there. It is often uncomfortable, and incontinence is made worse as a result of lack of estrogen. So as a result, if sex is painful, it's very hard to do your libido well. So we've got to renovate our friend here. We've got to bring her out. Less than 7% of women talk about this with a doctor. I love vaginas. I talk about it all day. Every time I do a pap test, I'm like, do you want to talk about like how's she going? You know, she looks like she could use a bit of help. Oh no, she's fine. You know, like I talk about vaginas all the time. Anyway, okay. So the best thing you can do for her is estrogen. And for you, I have great news. Every oncology society and every menopause society says that putting estrogen directly into the vagina, which is more effective than being on HRT, by the way, for vaginal symptoms, is absolutely fine, even for people who've got estrogen receptor positive breast cancers. 1 day on oral HRT is the same as 1 year on vaginal HRT. It is exceptionally safe. It is something that it's just such a no-brainer. But here's the bad news. The later you go on it, the less good we can ever make her. We can't get it back. The later you start the vaginal estrogen, the less good we can ever get her. She stays not so great. So we can always improve it, but start earlier rather than later. And if that is not enough, in 2022, we are going to get another couple of products here in Australia that we already have in the UK. So one of them is Crusterone, which is DHEA. That is a adrenal gland precursor androgen. So the adrenal gland spits out these kind of very basic hormones that then can be modified into estrogen, progesterone, testosterone, and they have very high affinity for the vagina. We're going to be able to shove her up the vagina as well, and that we think will also help your libido. So that's coming next year, and that's estrogen free. And then we have laser. The currently available lasers are not safe. So don't be fooled by anybody who's offering you vaginal rejuvenation via a laser. They are dangerous. I would be staying well away. But Professor Jason Abbott at the University of New South Wales and Royal Hospital for Women is currently conducting a study on a particular type of laser with a particular protocol. We know that laser can help build collagen and elastin in our skin. That's why a lot of us go and have laser treatments and Fraxel and all the rest of it. It is going to do the same thing for the vagina. We've just got to find the right one. We're not there yet, but watch this space. I would say that trial will come out next year, and then there will be vaginal lasers. And at that point, you'll be able to have 2 or 3 treatments and not need to worry about estrogen. If you're going to do a lubricant, I find personally most of the lubricants on the market are horrific. I mean, KY jelly is great for a colonoscopy. It's not great for health. The other thing that happens to men as they get older is while you were so happy that they, you know, you were happy if they went past 3 minutes when we first got married, as they get older, the nerves are not so good. And all of a sudden that battering ram is in there for 15 minutes. And you're just like, oh my God, can we stop this, please? KY jelly is not going to work. It's just not going to cut it. So I would go for coconut oil. I'd warm it on your hands. It's a stayer. It's a stayer. I'd rub it on your hands, rub it on him, and that will stay. That's probably your best lubricant. I would go for that one, and I don't think any of the commercial ones on the market are great. In terms of vaginal moisturizers, I'm not allowed to say brands, but I do like, there are some with hyaluronic acid in it, and that you put them up the vagina every 3 days. They're pretty good. That's the one I'd go for if you're going to supplement. But yes, everybody, even with breast cancer, can have estrogen in the vagina.
Are you giving us discounts?
Should have got sponsored by
pharmaceutical companies that isn't interested in this anymore. Fair enough.
Yeah.
Good idea. Yeah. Okay, so we've spoken about down there. We've spoken about the hot flushes. You touched on mood swings. Can we talk a little bit more about the mood swings and what we can do to sort of regulate that?
Yeah. It's really devastating.
And the brain fog.
Yeah, brain fog. Okay, brain fog is related to low estrogen, and it tends to do much better on HRT. We have no other treatment for it. There are whole lots of things that you can do. Exercise is great for your brain. Being happy is great for your brain. Sleeping is great for your brain. If you don't sleep, you cannot wring blood out of a stone. And if you're not sleeping, you're not going to have, your brain's just not going to function. It's not going to work that well. In terms of the mood swings, I find this really devastating. I see women who have great mental health, but this is a time where whether you've had bad mental health in the past, you know, a bit of postnatal depression 25 years ago, or you've ever suffered with it, comes out now, particularly in perimenopause. It actually gets better when you've gone through the menopause, but perimenopause is a time where 1 in 4 women will have quite a major mental health problem, and it's not spoken about. A lot of women are exhausted. They've been up all night. They've been having hot flushes. Sex is uncomfortable. They don't know what to do about that. That's causing some issues in their relationships, their progeny. We know that mental health is worse during perimenopause if you've got additional stresses. So lack of social support, clearly not an issue here, but lack of support from family conflict, financial issues, those things do contribute to mental health issues in perimenopause. Alcohol use, it's a time where Australian studies have found, particularly during the pandemic, that wine o'clock has just become pandemic amongst well-heeled, well-educated women. So I'm guessing that everybody here, drinking has crept up, and it's not great for your mental health. And a lot of women don't realise that they're reaching for the wine because they're trying to self-medicate out of a lot of stress and anxiety. If you find yourself having palpitations at the drop of a hat, the things that you used to normally sail through, like traffic, are all of a sudden, you know, you've got aches and pains everywhere because your muscles are in spasm because you're so stressed out. This is a time to go into help. Very few of people will need antidepressant medication. So antidepressant medication, depression at its worst is a fatal illness. You know, we all know somebody who's died of suicide. It's a very devastating condition, but it's not like everybody who has a bit of palpitations and anxiety or fights with their husband is necessarily, not everybody needs it. Studies show that for mild anxiety and depression, things like going for a walk, doing good exercise, speaking to a therapist who you connect with and who is good, those sorts of things are just as effective. So why would you go and take a drug? I'm happy to prescribe it, and I do prescribe them. And if you need them, we will. If you can't go to work, if you can't function, you're not able to. I mean, I've got patients who can't, you know, have a shower. Can't clean their teeth. They just can't get organised enough to do that. You need to have something. You can't get through that on your own. And no one's telling you to pull your socks up, but you want to look after yourself as well. And there's nothing that a pill is going to be able to do that you can't, that is going to replace taking care of yourself. Self-care is really important at this time, as it is in every other time. But HRT often does play a role. And while it wouldn't be the only reason you go on it, most women have some other symptoms of menopause, and we'll chuck it into the bucket. You know, we'll chuck it in and go, you know what, let's try it. It may not work, but for so many people, it does work. And then I would give my patients the option to go, here are all the things we can do. What do you want to try?
Excellent. Thank you.
Anybody listening to the rumor that HRT causes pimples and weight gain?
So let's take those apart. Acne is not uncommon during perimenopause. So about 1 in 4 women will get a flare in acne, particularly if she's had acne before. It's got nothing to do with HRT. So acne is caused because, remember how I told you you've got that progesterone factory that happens after you've ovulated? The way she makes progesterone is she takes testosterone that's come out of the adrenal glands and out of the ovaries. She puts it through that factory and spits out progesterone. If that factory doesn't work, you get a big increase in testosterone. So a lot of women will get hair loss, chin hairs, and breakout. That's just, the acne will go away once the testosterone goes away. The chin hairs will stay forever. So hello, laser, go and get to know her. That's just part of what happens, and they'll stay with you even after menopause is
I
gone.
wasn't going to talk to you about chin hairs, and the reason is you start getting the chin hairs, but you start losing your eyesight, so you can't.
That's what God invented the rear view mirror for, and driving into the sun. You know, that's why you keep tweezers in your car. So acne breakout will not be caused by HRT, and to a certain extent, estrogen counteracts testosterone. So no, it wouldn't. In terms of weight gain, that's a really, really common theory, and in fact, it's not been borne out. And in fact, if you think about it, all the symptoms of menopause that include exhaustion because you haven't slept, mood swings, hot flushes, vagina gone to shit. You don't exercise, and you often comfort eat, and you're often drinking. Give up that because you feel better, and you're actually going to lose weight. So studies show that actually you're more likely to lose weight, not because of changing your metabolism, not because of anything that the estrogen does, but because you are going to feel better and therefore be able to look after yourself and do that self-care that will allow you to shed those extra few kilos.
So just touching on the sleep, I've got a friend who didn't come this morning because she said if she gets a good night's sleep, she's not going to wake up for this. So can you tell us a few tips and hints around how do you sleep better during menopause, perimenopause?
So sleep goes to custard. There are a few things that happen. Your melatonin, which is your natural sleep hormone, so it comes on in the dark, goes off in the light. It really, the levels plummet around, particularly around perimenopause. And then there's another set of hormones called the orexin hormones, and they actually don't put you to sleep. They regulate your sleep and keep you asleep. So you can all tell they've gone, right? They're not in a good state, your orexin hormones, because most of us fall asleep fine, but it's just that staying asleep is just so hard, and it doesn't help if your bladder's not great. So if you are peeing 2-3 times a night, get your bladder sorted, because we can do that. We can maybe throw in some hot flush relief at the same time. But in terms of how we get you sleep, we know there's all the natural things. Exercising, don't go to bed on a full stomach because that can give you reflux. But actually 45 minutes before bed, having a low GI carbohydrate-rich snack actually has been shown in studies to improve your sleep, because your brain can't use fat, can't use protein, can only use sugar. If you had something like a Vita-Wheat cheese about 45 minutes before bedtime, that actually helps you with your sleep. So that would be one tip. But have your dinner as early as possible. We are so going alta cucka now, aren't we? Totally like 5 p.m. dinner is just working a treat. I would cut out your alcohol at night. If you're not sleeping well, alcohol does not help regulate your sleep. And then if you're really hardcore and you're a hardcore non-sleeper, we might need to look at some medication. I really don't like the addictive stuff. So my first choice would be maybe to try some melatonin, which you can now get over the counter, and you can try that for yourself. If you like it, you can go to your doctor and get it on prescription because it's cheaper, but just try it for yourself and see whether you like it. The other one that's kind of new is suvorexant, which is an orexin stimulator. So it actually helps you stay asleep. Suvorexant.
Is that over the counter?
No, that's you need a prescription for that. That has not been found to be addictive, and it doesn't so much put you to sleep as keep you asleep. Really great for menopausal women. It just can cause a bit of a hangover the next day. So I always say just muck around with it. What would be a great thing is get out into the sunshine as soon as you wake up. Even a cloudy day has got enough sunshine to switch off your melatonin, so that's really important. But the other thing is you can take it earlier than you think, because it's not going to put you to sleep. You can probably take your Suvorexin around 6. It's not a problem. And then you might need to play around with it just to make sure that you're not too hungover the next day.
And Ginni, sorry, Circuit.
Circuitin is melatonin. That's the 2 milligram melatonin that you get on prescription, but you can get melatonin over the counter now.
What about magnesium?
So actually, yeah, magnesium. So that's my sleeping pill of choice. I love it. So we've got 2 studies that show magnesium. One of them, magnesium calcium, which I don't love calcium supplements. I'll explain why. But magnesium, I think, is a great option. We know that 1/3 of Australians are naturally deficient in magnesium. It's in a lot of like whole grains and chickpeas and things like that, nuts and seeds. So a lot of Australians are deficient in magnesium. There is some in green leafy vegetables like kale, but if you're in an all pasta diet, mainly that happens when you've got little kids because you can't be stuffed to cook anything else and that's all they'll eat. But an all pasta diet, you're going to definitely be deficient in magnesium. And with magnesium, we've never had a case in the history of ever of a magnesium overdose. So there's absolutely no downside from taking magnesium. It doesn't accumulate other than like iron, which you can overdose on, or any of the A, D, E, K vitamins, which are fat soluble. You can overdose on those, but you wouldn't worry about magnesium. So yeah, that's a really good option as well.
I take that muscle ease magnesium at night, for not for sleep, but for joint and muscle pain. I find it really
Great.
helps.
Whatever works, you know.
I take that magnesium carver. Is that
Carver's great. It's had a few side effects, but yeah, that Carver's been shown in studies to be pretty good at putting you to sleep. You're not addicted to it?
No, I don't take it often, but
Good. Yeah, I keep it for an occasional one. Yeah,
That's
I think
magnesium oil.
it's the binder that often gives you diarrhea, because often it's put with aluminium, and if you have too much of that, that can give you the trots. So just be careful. If you go to the pharmacist and want a magnesium, just say, I want one that's not going to upset my guts, please.
Might solve that constipation problem.
Yeah, and you get into full-on irritable bowel because you're just lurching between, you know, it's horrible.
Fair enough.
Ginni, what were you saying about calcium?
Oh, so calcium is a really interesting one, because we think, right, we've got to look after our bones. Osteoporosis, fractures are hideous. I mean, really, the stats on hip fracture are so bad. Within 1 year, 40% of us will be in a nursing home or dead. Like, it's so bad. It's such a bad fracture. And the biggest risk for a hip fracture is having had another fracture. So you might think that fracturing your wrist is just a pain in the bum, but it's a risk for hip fracture. So we've got to prevent osteoporosis. The problem is with calcium supplements is that we've got now 2 studies that have shown that calcium supplements are linked to ischemic heart disease, having a heart attack, and a 30% increased risk. So we're far better off getting calcium from your food. The DASH diet, which is the diet that's been proven for high blood pressure. So I don't know if anyone who's got high blood pressure here would have been put on the DASH diet. We want more potassium, less sodium, more calcium. So I know dairy's a bit on the nose. We're going to have to get rid of it if we're going to decrease our methane emissions. But dairy is the best source of calcium. But if you are vegan or lactose intolerant, I would probably see a dietitian about actually getting a nutritious source of calcium. The ones that really worry me are like the almond milks and that are all full of sugar and no nutrients at all in them. And so I would probably go soy milk is a really good option, because it's well, so in terms of if you're going to go through all the brands, you can see some of them have been supplemented with calcium. Yeah, so we've got no evidence that calcium supplementation into food, because a lot of cereals, you know, our kids' cereals are packed with vitamins and stuff that's all been put, because so many kids have got such a car crash diet. But even bread in this country, white bread has got folic acid in it and all sorts of things like that. But I would, if you are vegan or lactose intolerant and you cannot get 3 serves of dairy into you a day, it's the best investment ever to go and see a dietitian, a proper dietitian, not, sorry, I hope I'm not offending anybody here, not a nutritionist, not someone who got their degree out of a cereal box of an 8-week course that they paid for. I'm talking about a proper dietitian. is who you want to go and see for a proper calcium sources, because I find a lot of personal trainers who've done that course in nutrition just tell everybody that coffee's poison, sugar's poison, dairy's poison, get off it, and they don't give them any advice about getting calcium into their diets. And that's for us women, putting us at huge risk. And osteoporosis is a much bigger killer in Australia than breast cancer. You want to avoid that. It's not great. Caltrate, forget it. Just no caltrate. No caltrate.
Sure.
No. So my practice is not in this area, but Susie Burrell in Bondi Junction is excellent.
Susie, it'll be on the recording. Susie Burrell.
She's excellent. She's an excellent dietitian. She's extremely knowledgeable. Susie Burrell. She's just hard to get into, but she's outstanding. I just don't know enough people around here because my practice is down south. So I don't, but I would say anybody who is a proper dietitian, as in they've done a science degree and then done their master's in nutrition, which is how you become, it's hard to be a dietitian. It's really hard. They know far more science than I do. They have to have done full degrees in biochemistry. They know all the way that the nutrients interact. They are a great resource for you. I really don't care who it is. They're going to be great. But it's that would be, one session just to say, how do I protect my bones? And that's how I would do it. But caltrate, the problem is we've got these studies that show it increases your risk of a heart attack, and so I'm a bit concerned. So where the question is around milk powder, you'd have to look at it. So some of the problems with milk powder is that they put a lot of the fat in and a lot of the protein. So most of us actually have too high a protein intake. We need more plant-based, we need more fiber, we need more whole grains, we need more vegetables. Very few of us need more protein. Most of us probably need to be cutting out protein. And very few of us are going to need more of the solid dairy fat, which is saturated fat, in our diet. So yes, it's going to give you the calcium, but I probably prefer that you have a low-fat milk and have an extra latte than have an extra bit of the powder, because I think there's just a concern around your cholesterol and your cardiovascular risk there. It's sort of, it's hard.
That's a question about the marina.
Yeah,
That's,
love the marina.
a lot of GPs and doctors have said that it actually helps quite a lot to get through menopause without.
Wow. Okay, let me try and unpack that.
Well,
yeah.
Whether it masks symptoms,
No, it
whatever
doesn't.
is, I don't know.
No. Okay, that's someone who needs to upskill on their education. Okay, so Marina is a progesterone containing contraceptive device that is an IUD, and it puts out 20 micrograms of levonorgestrel, which is a particular type of progesterone, directly into your uterus every day. At that dose, it's not enough to get into your bloodstream and change what would be your natural cycle at all. So unlike the Implanon, which is the rod, which works also with a high dose of progesterone, but it does that at such a high dose that it actually interrupts your cycle. You won't ovulate, you won't have periods, it sort of shuts it down. This just basically operates. Remember how I told you a lack of progesterone in the uterus will actually cause extremely heavy periods? This is the opposite. If you have extremely heavy periods, we're putting progesterone in, and it will certainly control the heavy periods. And for the 1 in 4 women who get heavy periods during perimenopause, it is a good first option. It is often not enough. I've had lots of patients where the marina's been bled out. I mean, if your periods are heavy, I've got a marina. I love it. I don't even want to think about what my periods would be like if I didn't have the marina. I'd be Armageddon. I wouldn't be here today, that's for sure. I love it, but it's not for everybody. In terms of it being able to control your lack of estrogen and the symptoms that happen as a result of the estrogen, it's not possible. It doesn't do anything like that. It's specifically for heavy periods. And it specifically is, the advantage of it is it doesn't get into your bloodstream where it can't do anything, which is a great thing. That's its selling point, is that it doesn't give you progesterone, which is, women really worry about that because progesterone is linked to, particularly to weight gain. And so a lot of women really don't want to have high doses of progesterone in their body because they don't want the breakout and the depression and the weight gain.
So then it does benefit you.
If you've got heavy bleeding, it may.
It may.
I love
Only
it.
for the bleeding.
Only for the bleeding, nothing else. Yeah.
2 questions. Firstly, is there a link between like menopause, HRT, and dementia?
Oh, that's such a great question.
So the question is link between menopause, HRT, and dementia.
So there was a very large study that came out showing that HRT, shock horror, had an increased risk of dementia, and everyone went, oh my God, didn't see that coming. That was like really horrifying. Other studies have come out showing the complete opposite. And the reality is it probably doesn't do anything much. It probably doesn't affect you one way or the other. The thing that I can tell you is lack of exercise is linked to dementia. Depression is linked to dementia. Being depressed and not addressing it is linked to dementia. Heart disease is linked to dementia. Not eating properly, having too much alcohol, not sleeping, all of those things are linked to dementia. So having a horrible menopause, and we know that dementia is the leading cause of death in women in Australia. Dementia hits us twice the rate that it hits men. It is a female issue, but having a horrible menopause that is protracted over a prolonged period of time probably predisposes you to dementia. And it's possible that people who take HRT are the ones who've got the worst one. And some people have sailed through menopause, so why would you go near HRT? There's no point. And so those people probably, they keep exercising, they keep doing really well. They don't need the HRT, and then they also have a lower risk of dementia. But it probably doesn't protect you either.
Is it not linked to, so basically I had shopping periods at the marina, nothing worked.
Yeah.
So I just had a hysterectomy.
Yeah.
And it was perfect, kept my ovaries, and went straight into menopause.
We should talk about that, about hysterectomy. I call it
my questions. I
it's
was
the
gonna get to,
H
so
bomb.
Thank you for asking.
No, but anyway, so this guy that I saw has said that if I don't go on the HRT, then my chances of getting dementia and Alzheimer's, I'm under 50, I'm 48. My chances, if I don't go on the HRT, are exceptionally high of getting dementia and Alzheimer's.
So
Both,
yeah, so what most Menopause Society guidelines are is that you should stay on estrogen, whether that's naturally by your body or via HRT till you're 50 or 51. There are different Menopause Societies say different things. To protect your heart, to protect your bones, to protect your brain. The data behind the brain is the weakest, but the data for protecting your bones and your heart is the strongest. Can we just talk really quickly about hysterectomy? Because it's something that a lot of us are going to come up against, and we should probably talk about it. So I drop the H-bomb with caution on my patients because they often go. I remember my grandmother had a hysterectomy at 35, took to her bed and never was the same again. They used to take everything out, and they used to throw them into surgical menopause, which is just cruelty itself. It's awful. And there's something that happens when your ovaries go into a slow retirement. It's, believe me, no matter how bad it is, it's not as bad as a surgical menopause where you go boom, from one day, perfect fertility. So hysterectomies will bring your menopause forward between 1 and 2 years, statistically. So that story of women having a hysterectomy and then going immediately into menopause is very, very common because it hastens your menopause. And often you're having a hysterectomy for results that are related to a serious perimenopausal problem. So as a result of that, it makes sense. We've brought it forward from 51 to 49, or from 50 that you might have been to 48. That's very, very, very common. Here are the advantages that no one's going to talk to you about. And this is, I'm going to take my doctor's hat off and talk to women about. If you have no cervix, you are not going to get cervical cancer, and you don't need to have a pap smear. It is a redundant organ. At 50 years of age, you are not using it to incubate a baby anymore. It's done its job. It's done a great job for you. Yeshakoyach, amazing. Now you can let go of it. It doesn't do anything for you. We also know that women who have a hysterectomy halve their risk of ovarian cancer in their lifetime. Now, why that is, we're not sure, but they halve their risk of ovarian cancer. No one talks about this stuff, but also they can also often fix your pelvic floor while they're up there, because it's really easy. They just do this birch culpo suspension where they just kind of stitch it up, and all of a sudden you come out, you've had a hysterectomy and you can run. It's like, whoa, where did that come from? Amazing. But there are things that can be done that are excellent. The other thing that we can do is give you estrogen only HRT. If you remember, we only need to give you progesterone for the protection of your endometrium. If you don't have a uterus, we don't need to give you progesterone. Now, we may choose to for 2 reasons. Number one, if you've got depression and anxiety, progesterone's outstanding. The other thing is there's some new research. I just went on a webinar from the European Menopause Society where they presented some new data around progesterone's benefits for the brain and preventing dementia. Hence, I've got a Mirena, but I'm taking a bit of progesterone. Kind of like what I'm hearing. But you don't need it. And most of the issues around breast cancer were linked to taking progesterone. And in fact, the estrogen-only HRT arm of the Women's Health Initiative study, that study that we hate and wish should never happen, actually showed a reduced risk of breast cancer. And that was data for 16 years of taking estrogen-only HRT. That's not an option for someone like me. I've got to use a Mirena and maybe use a bit of progesterone as well, but it's great for someone like you. It's a great option. You can actually take estrogen-only HRT and actually know that not only have you reduced your risk of ovarian cancer, but breast cancer as well. So that's it.
I've got another opinion, and they said to not take progesterone, just take progesterone. That's it. Most doctors
Was that from a naturopath?
from a doctor.
Like that.
I apologize to my colleagues. It's really hard to get good, a good, yeah, okay.
She said just the time, like they said, just a little bit at a certain time, like to follow what's going on, and then just progesterone. So I had like,
I have no,
Let's take that one offline. Maybe go
so
do
you saying
something.
not progesterone.
don't do anything for you.
So just one last question before we wrap up, because we've gone over time, and that is we've asked most of them. So the last one was, what about menopause on the mini pill? The mini pill. The mini pill.
So mini, I think the progesterone only pill.
Menopause went on mini pill.
Okay, so the mini pill is a progesterone only oral pill that is given to breastfeeding women so that they don't shut down their milk supply.
Right.
So it's
So
not a
not
great form of
necessarily-
contraception. In this group, I would have thought mini pill use would be
Quite
no
low.
judgment, but it doesn't look like anyone's breastfeeding. I don't know.
Go ahead.
My question should be there about a product called Metagenics.
Ah, I apologize. Skipped it. So Metagenics hormone support supplements, and you continue taking it for more than 6 months.
You know of it? Only.
I can't comment. It's not a product with any evidence base behind it. It wouldn't be something that a doctor who's got experience in menopause would recommend. I would stick to evidence-based products.
One more question.
Yes.
You say you can't have a blood test for perimenopause. Can you have a blood test for menopause?
Yeah, but you kind of don't need it, right? Because you kind of know. Like menopause is 1 year since your period. Here's as good as a blood test. Oh, it was 15 months ago. You're in menopause. I need to diagnose that. There you go. You're done. I mean, I'm probably going to do one for cholesterol because it's a good time to do that. But like, I don't need a blood. Well, what I need it for is for women who are on Mirena, who haven't had a period for so long they don't even know, or who've had a hysterectomy and have got no idea. Then I need a blood test. For everyone else, I don't need it.
If you have a Marina, how would you know?
You might need a blood test. But if you're having like some symptoms like all of a sudden, yeah, so you're having some hot flushes, you're depressed, you're having some aches and pains, I'll do a blood test.
We'll do it later.
Yeah.
Itchy skin.
Oh, yeah, huge.
A common symptom.
So common. And actually there's formication where you feel like bugs are crawling on your skin is also a common symptom of menopause. Yeah. So yeah, we can take it offline. It's about, so you've lost collagen, you've lost elastin, and you've got a huge amount of transepidermal water loss. So you just get dry skin. So we've got to rehydrate your skin, and probably I would be using vitamin A on your skin there just to put in some collagen and elastin. Yeah.
Thank you very much. Just before we wrap up, did you want to say anything about your book? Where it's available?
Best book ever. Why would you not buy it? It's so good.
It's a Christmas stocking filler.
Where can we buy
Chris
it?
Pringle.
Yeah. It's on. It only came out last year, so it's everywhere. Online.
Is there a study guide for husbands? Have you got like a show?
I swear I do. It's the last chapter, which says, and honestly, one of the things I say in there, like my wife never wants to have sex. What's wrong? And it actually says most men I know are Olympic level masturbators. Go perfect the art. Yeah, it's in there. I tell the guys to go masturbate. There you go.